So how many of you come across PDA? Just raise the hands. Clinically? Yes. How many of you come across VSD in adults? Some 4-5. How many of you have come across ASD in adults? Right. Top பார்த்திருக்கீங்களா adults la? Top in adults? No. So the very first question, which of the following is the commonest congenital disease in adults? Commonest நீங்க பார்த்து நீங்க யோசிக்கலாம். Which of the commonest is ASD. Okay. So it's not VSD, PDR, but it's ASD. So congenital disease in adults. Okay. இதில் அந்த பாயிண்ட் வர மாட்டேங்குது. வந்துன்னா it's easier for us to. Yeah, got it. Isn't it? Yeah. So it is 1 in 150 adults live with congenital disease. It's not that uncommon. Most would have received treatment when they were young, often in infancy. Rarely people go undetected until much later in their life. See, if you see congenital disease in adults, these are the asymptomatic lesions which cause minimal or no symptoms. That's why they grow up as adults with the lesion. Atrial septal defect, even if it is very large, asymptomatic. Partial or hemianomalous pulmonary drainage, patent ductus arteriosus, VSD generally small ones, valvular lesions, mild to severe lesions. Even severe pulmonic stenosis sometimes can be asymptomatic. Coarctation of aorta and corrected transversion of great arteries. Which are the cyanotic heart diseases which can present in adults with minimal or no cyanosis? Pink tetralogy of and Epstein's anomaly. Of course, the cyanotic lesions are top-like situations and Eisenmenger syndrome. So these are the group of congenital diseases which we see in adults. Let us come to the most common atrial septal defect. This is a left to right shunt at the level of atrium. Right ventricle and right atrium are volume overloaded. There is no pressure overload. There is a gross difference between VST and AST. Suppose there is a large VST with 3:1 shunt. That means the pulmonary blood flow is 3 times the systemic blood flow in a 6-month-old child. The child will be very symptomatic. Same 6-month-old child, large AST, pulmonary blood flow is 3 times the systemic blood flow, 3:1 shunt, but asymptomatic. Why? What's the difference? In large VST, the left ventricular pressure is directly transferred to the right ventricular pressure because of the large VST. So LV pressure is 90, RV pressure is also 90. The RV pressure will be there in the pulmonary artery also. Pulmonary artery hypertension also will be there as a part and parcel of large VST. So a large VST is a volume overload plus pressure overload, which the child cannot tolerate. Child will come with heart failure. But in AST, though the pulmonary blood flow is increased 3 times the systemic blood flow, there is no pressure overload. Pulmonary artery pressure is normal, which is easily tolerated. Lungs will easily tolerate volume overload. Heart will easily tolerate volume overload, but not the pressure overload. That's why, for the same shunt, large AST is well tolerated. They'll grow up into adults without symptoms. Whereas the large VST is not well tolerated. They'll manifest in the infancy. So we have hyperemic lungs. Cardiac output is unaffected. It can be increased with demand. If pulmonary arterial hypertension develops, pulmonary blood flow decreases. The RV volume overload decreases, but the RV volume overload is replaced by RV pressure overload. So RV remains enlarged. Now the cardiac output cannot be increased on demand. This patient becomes symptomatic. So suppose you know a large AST patient, you have recommended surgery, he is not operating because he is asymptomatic. Sir, nalladan sir irukku. Enna sir? Adana enna sir? Now the asymptomatic patient now comes with symptoms, it's a dangerous sign. So development of symptoms in AST is a dangerous sign. Okay. It's a reverse. If a large VST child, 6-month-old child, 8-month-old child, significant symptoms. When the mother says now symptoms are coming down, means either it could be VST size is coming down or the child is developing pulmonary vascular disease. So in VST, symptom coming down can be good or bad. But in AST, development of symptom, asymptomatic patient becomes symptomatic is generally a bad sign. So AST in older patients, with age, LV stiffness increases with increased LA pressure. Many patients develop systemic hypertension which contributes to LV diastolic dysfunction, increasing further LA pressure. Hence, an symptomatic AST in the 3rd decade would present with heart failure in 5th or 6th decade. So a large AST will not always go for Eisenmenger syndrome beyond 40-50 years. Only 20 or 25% will go. The rest of the 75% will still remain left to right shunt. But what will happen? A so-called moderate AST at 30 years of age which is shunting 1.5 or 2:1 shunt, will be shunting 2.5 to 3:1 shunt at the age of 45 or 50 because of the increase in the LV diastolic pressure, because of the decrease in the LV compliance, because of the increase in the LV pressure. So we cannot say just because it's a moderate AST, just because patient is asymptomatic, just because patient is already 25 years, it doesn't guarantee that he is going to remain asymptomatic at the age of 55 or 60 years. That becomes an indication that whenever there is significant shunt, that has to be closed, even if the patient is asymptomatic, even if the patient is adult. So please read the last line. An asymptomatic aged in the third decade would present with heart failure in fifth or sixth decade. At that time, treatment is going to be much more difficult, and the outcome cannot be guaranteed as we can give an excellent outcome in the younger individual. So symptoms could be precipitated by the development of atrial arrhythmias, especially atrial fibrillation. Systemic desaturation signs develop once the patient reaches the ischemic status. So what are the indications to close ASD? Small defects less than 1.5:1 not indicated. Moderate to large defects are more than 1.5:1, or when there are RA and RV overload by echocardiography, it needs to be treated. Majority, 90% of secondary defects are amenable for transcatheter device closure. So if the large ASD is closed before 35 to 40 years, complete recovery and regression of right heart is possible. Majority will have near normal heart, good recovery of RA and RV, and late arrhythmias are uncommon. But if you close later, beyond 30, 35, 40 years, his exercise symptoms will improve, he'll become better, but the enlarged atria will remain enlarged, and they still run the risk of developing atrial arrhythmia subsequently. So that comes another indication why we should close early. So when you close early, not only that you are preventing the heart failure, you are practically curing the patient. But when you close later, okay, you are kind of taking away one important component of the heart problem, but the arrhythmic component still remains. So that's why it's important to close early. Closure is indicated in any symptomatic patient, even if he is more than 50 years of old. Okay, ASD. So this is one device closure. Just to give an example, it's a relatively straightforward procedure if the anatomy is suitable. So what about VSD? It's usually restrictive in nature in adults. Usually small defects with no increased pulmonary blood flow will be seen in adults, because most of the large defects would have present in infancy, either got corrected or the child would have died. Moderate VSD generally would have got exposed by the good murmur, would have got rectified by surgery, or they would have become smaller. So most of this VSD we see in adults are small. Moderate size defects are can be seen where the QPQS is 1.5:2, LE volume overload may be there. Large or non-restrictive defects generally would have become inoperable in adulthood. Actually, the inoperability of VSD sets in very early, the first 1 or 2 decades itself, the first 1 or 2 years itself. So those who are destined to develop ischemic syndrome, the reaction starts very early, in the age of 1 to 2 years itself. Not that the ischemic status occurs after 10 years. By 8 to 10 years itself, it would have been very much become inoperable. So again, large VSD we have to treat before 1 year, because we do not know who is going to develop actually ischemic syndrome. We cannot wait for 8 to 10 years. We have to close before 1 year. It's an example of VSD device closure. It's not running here. The previous one was running. So what I'll do, just to give you a feel of those who are in the, so this is the, hope it runs here. We cannot support this image. Let me just try once, open with, we'll see media player. Yes, it runs. Okay. So the catheter is in the left ventricle. This is the descending aorta. This is the arch of the aorta, and the gas in the left ventricle. You can see the flow into the right ventricle. This is the interventricular septum. The contrast-free area is the interventricular septum. That is a flow. Okay. Can you see the ventricular septal defect here? And after the VSD device has been implanted, and you can see the VSD device sitting there, and it's totally closed. So again, it's a relatively well established procedure, and majority of the adults are amenable for device closure, because usually there will be a tissue below the aortic valve, and I cannot remember sending any grown-up child or adult with VSD for surgery. So it's a relatively straightforward procedure. So whenever there is an VSD of significant size, as you can see here, a large LV, moderate VSD, one can always recommend VSD device closure if it is clinically indicated. So it's running now. Earlier it was not running. Anyway. So patent arterial duct Even small to large ducts can present in adults. LALV volume overload will be there many a times if it is moderate to large VST. Varying degrees of pulmonary hypertension is there, and one can diagnose this by continuous machinery murmur. If you are able to hear the diastolic component of the PDA, that patient is operable. You can straight away take it. Even by the echo wise, if they have given RVSP of 70, 80 and all, clinically if you are hearing continuous murmur, that means the PVR in the diastole is much lesser than the PVR of systemic atrial resistance, that patient becomes operable. Only when we don't have clinical diastolic component of the PDA murmur, then we have to ensure that he is operable before subjecting for closure. So PDA small to moderate sized, the risk of infected endocarditis is quite high. Large has the risk of heart failure. Closure is indicated even in small defects if there is clinical murmur. Anyway, I am not getting the pointer here. So PDA closure, transcatheter, we have coils and devices. There is no role for surgery in the current era for PDA, except for very small infants less than 3 months. In selected children, we do send them for surgery. Beyond 3 to 4 months, there is no role for surgery in the current era for patent ductus arteriosus. Bicuspid aortic valve, I won't call it as a disease, but can become a disease. It's very common, 1 to 2% of population. Male to female ratio is 4:1. 20% of them have associated coarctation of aorta and PDA. Late aortic stenosis can develop beyond 60 years, as Dr. Selomani showed in his transcatheter aortic valve replacement. Nearly 60% of them had bicuspid aortic valve. So these bicuspid aortic valves, which are asymptomatic for long years of 50, 60 years, they have higher preponderance to develop calcification and present as aortic stenosis beyond 60 to 70 years. They have high incidence of infected endocarditis. These are the ECG and echo is how we diagnose. And they are all very much amenable for balloon angioplasty. Bicuspid aortic valve is very much amenable for balloon angioplasty. We do at least once or twice, and if it comes for the recurrence after the second time, we'll send them for surgery. So we don't send for surgery straight away if it's a bicuspid aortic valve. So coarctation of aorta can be simple, complex, or it can be asymptomatic or symptomatic. When do we call significant coarctation? When the translesional pressure gradient is more than 20, or if the patient has upper limb hypertension, that means there is significant coarctation of aorta. So these are the presentations: epistaxis, headache, leg weakness on exertion. Leg claudication is quite rare because generally they develop collaterals. Peripheral arterial diseases, leg claudication is very common because collaterals are not that much. Whereas in coarctation, generally collaterals are significant. So leg claudication is less common. So brachial pressure is more than popliteal pressure by 10 millimeters of mercury. You may have murmur in the front or chest. And intervention is indicated whenever there is a BP difference, radiofemoral delay, and the peak transcoarctation gradient is more than 20. You can see this example. This is a lateral view of an aortogram, descending aortogram. So what you see here is a coarctation site. And you see a small balloon-like thing, isn't it? Actually, this balloon-like thing is nothing but the original patent ductus arteriosus. The original patent ductus arteriosus, the end is closed, but still the ample of the PDA is remaining. Okay? So we have a small aneurysm-like thing sitting at the level of the coarctation of aorta. So how do you manage this? We can manage by either you can do a separate closure of the aneurysm and then do the coarctation of aorta stenting, or you put a covered stent. This is a covered stent across the coarctation of aorta, deploy it at the site of coarctation of aorta. This is not only the cobalt chromium stents are there, but it's also having a lat cover. So after the thing, you can see that with a covered stent, you can remove the the aneurysm is now not in connectivity with the descending aorta. So the aneurysm is excluded and coarctation also treated. So right ventricular outflow tract obstructions, all these things are possible. We can come across in adults. Simple valvular pulmonary stenosis, supravalvular pulmonary stenosis, or infantile stenosis, all can be very much possible. As usual, whenever there is a pressure gradient of more than 50 millimeters of mercury, balloon pulmonary valvulotomy can be done. Generally, it gives good result. Tetralogy of Fallot. Okay, these are the varieties of tetralogy of Fallot. Everybody knows what tetralogy of Fallot is. Basically, there are two main components. One is large VSD, another is pulmonary stenosis. Depending on the degree of pulmonary stenosis and depending on the area of pulmonary stenosis, the patient presents with cyanosis. Now, adults many times, a relatively mild desaturated pulmonary artery, tetralogy of Fallot, that saturation can worsen and they present with severe cyanosis in adults. This is one such example. Like, this boy is 19-year-old boy, present with a saturation of just 55%. He was seen by us 10 years later. He didn't come for 10 years. At that time, the saturation I had mentioned was 86%. And now see, my catheter is in the right ventricle. I'm injecting in the right ventricle. The entire contrast goes only into the aorta. Nothing is seen in the pulmonary artery. We don't see any pulmonary artery in the lung field at all. If you notice, there is some calcification here, just to the left of the aorta. So that is the site where the usual pulmonary artery is present, isn't it? The usual pulmonary artery is left and anterior to the aorta. So in the place where left and anterior to the aorta, we have pulmonary artery, there is calcification. So I could guess that there is something there. I went there, probed there, so put in a wire, okay, and then I dilated that calcified area with a balloon. It's a 16 millimeter balloon. After that, the anti-gate flow was re-established and we could see the pulmonary artery. So it is what we call as acquired pulmonary arteries here. He had anti-gate flow there. Because of calcification of the pulmonary valve and also further hypertrophy of the infundibulum, the anti-gate flow became totally cut off. He presented severe cyanosis. And this is a palliative balloon pulmonary valvotomy in an adult tetralogy fellow. This boy being just 19-year-old, I subjected him for intracardiac repair. He underwent, good repair was done and he is fine. Many a times, a 45-50-year-old comes with tetralogy fellow. This balloon pulmonary valvotomy is good enough to improve the saturation from 60 to 85. And thereafter, whether and subsequent intracardiac repair is going to benefit him or not is a big question mark. See, this is not an issue with adults tetralogy fellow in Western countries because they don't have any adults with TOF. We rarely come across adults with unoperated TOF, in whom we still occasionally, I have 4 patients in whom I have only done balloon pulmonary valvotomy and they're simply followed up because the saturation is more than 70%, they are likely to be asymptomatic. By subjecting them for ICR at the age of 50 or 55, we do not know the outcome, whether it's going to be better, the natural history is going to be better than what we have already achieved. So congenitally corrected transposition of great arteries, again, it is a big kind of, discussion depending on whether the LV dysfunction is there, RV dysfunction is there, how much is the valvular regurgitation, and whether the presence or absence of other VST and things like that. So this is the other one which you commonly come across, congenitally corrected transposition of great arteries. Of course, the commonest cyanotic heart disease next to tetralogy fellow in adults is Eisenmenger syndrome. And if you don't have any clear-cut clinical clue whether it is Eisenmenger syndrome or not, we'll go what we do as a bubble study by the echo and try to identify where the shunt is there. So Eisenmenger syndrome means there is right to left shunt with bidirectional shunt. If there is differential cyanosis, that is upper limb is relatively better, lower limb is much more sinus, then it's a PDA with right to left shunt. If there is uniform cyanosis, it's other than PDA, it could be AP window, it could be VST, it could be AST, all these things. Okay. So these are the usual drugs, calcium channel blockers, ACE inhibitors, prostacyclines, pulmonary vasodilators in selected cases. Even if there is polycythemia, there is no role for venesection. Both in Eisenmenger syndrome or tetralogy of Fallot, we should not do venesection even if the hemoglobin is 24. Like that boy who came with a saturation of 55, his hemoglobin is 24. But we did not do venesection, we improved the pulmonary blood flow. Once the saturation improved, 2 weeks later, just 2 weeks later, his hemoglobin fell to 20. And subsequently when the hemoglobin became 18, he became a good candidate for surgery. High hemoglobin or polycythemia becomes one of the important risk factors for post-operative complications in surgery. So these are the treatment Eisenmenger syndrome. So in general, medical management of cyanotic congenital heart disease includes treatment of hyperviscosity syndrome, avoiding dehydration, treat the iron deficiency whether it is absolute or relative, avoid dehydration, and cerebrovascular events are common in patients with uncorrected cyanotic congenital heart disease. We have to look out for that. And for the same reason, renal dysfunction also relatively common in them. So this is in short about various congenital heart diseases which you come across in adults. Thank you for the opportunity. Thank you.
Thank you, sir. This is an excellent talk on management of grown-up congenital heart diseases. Any questions to take? There will be a significant subset of patients in the adult population with neglected congenital heart diseases. So how are we going to manage this? We used to see a lot of AST. So any ASTs has to be closed if it is the adult age group. Tetralogy of Fallot, as sir has showed a very beautiful antegrade flow establishment, but there is LP aneurysm. This is because of a BT shunt or because of previous PDA or something?
No surgery was done. It's that some of the patients will have this medial hypertrophy and like what you see
but it's a very, very large
bicuspid pulmonary valve related weakening of the media and causing LP dilatation.
Yeah.
Right.
Other big subset is management of arrhythmias and grown-up congenital heart disease. Be
Yes.
very, very difficult to treat the
Exactly.
arrhythmias. The other thing is about, say I have a patient, 38 years old. 10 years ago, he underwent a sinus venosus ASD surgical closure. Now with frank right heart failure. 10 years he has survived, but now he has come up with swelling of both. I think so now we classify it as a pre-tricuspid shunt and a post-tricuspid shunt. All pre-tricuspid shunts are volume overloaded, post-tricuspid shunts are pressure
Pressure and
overloaded.
volume overloaded.
Both pressure and volume overloaded. So even in the later part of the childhood, or in the adult, whenever we want to close an ASD, always there should be a CAT study. You have to get a QPQS, and then because most of the times it's the ASD which presents, not the VSDs. VSDs most of the times we close it earlier, or whenever there is a symptom-free time, that is the time we have to intervene more, because we want to know that when we have to close this. So this is what is about. Sir has spoken very beautifully about management of grown-up congenital heart disease.
And not that all congenital disease lesions need intervention, but those who need intervention should be correctly identified and corrected. That should be the kind of message from this talk. Thank you.
How frequently we follow bicuspid aortic valves asymptomatic from childhood to adulthood? So
Bicuspid aortic valve.
bicuspid aortic valve.
See, if there is no AAS or AR, okay, every 2 to 3 years, once in 2 to 3 years is good enough. If something like AS and AR are there, 6 months to 1 year follow-up is needed. Those who have AS or AR, they are more likely to progress. That's why we follow more frequently. Otherwise, once in 2 to 3 years should be good enough. Bicuspid aortic valve, asymptomatic bicuspid aortic.
ASDs might be missed by predominant physicians, but the prominent click of the bicuspid aortic will easily they pick up, and we have to closely follow up them. At least if there is no ASAR, at least 2 to 3 years, we keep following it up, because now we know that severe aortic stenosis happens much more earlier with bicuspid aortic valve rather than with degenerate aortic valve.
Correct.
So I think it's very important to follow up these type of patients also. Thanks, sir. Thank you so much, sir.